And we are all glad to see you, Esraa, after being away for a year now.
Yeah, thank you. Thanks a lot. Hello, everyone. My name is Esraa Ali. First would like to thank Professor Mohammed today for such a great introduction that I don't think I really deserve, but you've been my mentor from the first day, so thank you for that. I would also like to thank Professor Mervit Shabrawi, our head of department, for organizing this great conference, having international speakers. Also, I'd like to thank Dr. Ihab and Dr. Mahmoud Ghanem for this opportunity as well. So today I'll just walk you through a case of acquired toxoplasmosis. Your next 15 minutes will be spent on a case of flutters in a 21 years old patient. I'll talk to you about the approach to a case of retinitis and how we manage our own case and give you just a small take-home message. So I have no financial interest. So you were in clinic with us, and we found a patient with a 24 years old female complaining of a drop in her vision with flutters in her left eye for 2 weeks now. She has no other symptoms, no other systemic complaints, or no family history that is relevant. So we proceed with examining our patient. As we can see in her right eye, everything is fine. Vision is 6.6 and all the other examination is fine. Looking at her left eye, the visual acuity is 612 or 0.3. Negligible refraction, her attention is fine, color, vision, confrontation, task, pupil, and anterior segment, everything was fine. So now we proceed to the exotic part of her examination, which is a fundus examination. Her right eye seems fairly normal. So we examine now the left eye with her complaints. As we can see now, there is a bit of haziness in front of the optic disc. So zoom in. We have a bit of vitritis with a retinal lesion. We can describe it as grayish whitish, maybe 1 disc diameter in size, maybe 1.5 disc diameter away from the disc. And the haziness that the patient, or the flutters that the patient is complaining of, is caused by the vitritis overlying this lesion. So we ordered an OCT. The cuts taken on the lesion itself showed, as you can see, the prominent vitritis that caused the flutters, with the underlying irregularity of all the retinal layers, inner and outer layers of the retina, subretinal fluid, and all of these are causing backshadowing over the choroid. But we can tell from the contour of the choroid that there's also some kind of choroidal inflammation, maybe. So we've ordered fluorescein and geography. So in the early phases, there is a bit of hypofluorescence, but following on, there is hyperfluorescence indicative of leakage and a bit of vasculitis as well. So our impression would just say that this is a superior nasal focal retinitis, 1.5 disc diameter in size, within 1 disc diameter from the disc. So as
could you raise your voice a little bit, please?
Yeah, sure.
Okay.
Sorry. We've ordered the usual lab screening for the uveitis, which would include usually the CBC, ESR, CRP, renal function test, the liver function test. You would order angiotensin converting enzyme to exclude sarcoid. You would order quantiferon to exclude TB, toxoplasma antibodies, syphilis antibodies as well, autoantibodies screening for all the autoimmune diseases that can cause uveitis, and chest X-ray to exclude sarcoid and TB as well. So these all came back with only positive toxoplasma IgG. So before we rush into saying what we did, I'd like to tell you, show you this great screenshot from a book called Decision Making in Ophthalmology, an Algorithmic Approach, which was actually recommended to me by Dr. Mohammed Salah, the previous speaker, my senior. So if you have a case of retinitis, you take the history, you review the systems, do an examination evaluation, just as you do with any patient, but then you can divide your patient into 2 segments. The first one is the immunocompromised patients, which always trigger in our mind certain things that attack the immunocompromised, such as cytomegalovirus and the ones caused by the herpetic family as ARN, acute retinal necrosis, and progressive outer retinal necrosis, and also the others. And then the immunocompetent as our patient, we can divide them according to how we see our patient or how we see the lesion. So it can be focal lesion or multifocal, can be neuroretinitis, peripheral geographic, diffuse, or predominant vasculitis. So for the range or for the scope of our talk, we're going to focus on our patient who had a focal retinitis. So we only have these small suspects or the differential diagnoses that we have: acute retinal pigment epitheliitis, Behçet cephalitis, systemic lupus erythematosus, and toxoplasma. So how do we differentiate? Actually, acute retinal pigment epitheliitis would also come in a young patient and would be unilateral as well. But on the OCT, it will only show the problem to be present in the outer retinal layers, or the RPE and the outer retinal layers only. Behçet cephalitis and SLE will either show on our lab test, or the patient would have systemic affection as well. So now we are narrowing everything to our toxoplasmosis. So just a few numbers about it: 80 to 90% of acquired toxoplasmosis in immunocompetent patients is subclinical. So you're not going to see an acute attack in a patient who just had the infection and will come with neuroretinitis. That usually doesn't happen. It only happens in about 10% of patients. Others will be subclinical. 50% of all toxoplasma patients are actually postnatal childhood acquisition. So it's not a congenital infection, as we always like to think. It actually compromises 20 to 60% of posterior uveitis cases. So it's a major suspect all the time. And the congenital cases, 85% of them are bilateral. Other thing I would like to note is that the diagnosis of ocular toxoplasma is usually clinical. So there is no reliable diagnostic test. So why are we doing the antibodies? Where usually they are not helping us to confirm, but the negative test would help us discard the possibility of being a toxoplasma case. Antibodies can often persist at high titers, so we don't depend on how high the antibody level is. And there's also high prevalence of antibodies in the general population. Actually, it reached about 80% of patients in South America. So with all of that literature review, we can say that our provisional diagnosis is toxoplasma retinochoroiditis. So the American Academy describes your decision clinically, that the clinical lesion would be a gray-white focal area of intense necrotizing retinochoroiditis, typically with moderate to severe overlying vitreous inflammation. So actually, this literally describes our patient. But what we always see is the recurring disease. We see the ones indicated by or adjacent to an old scar. But remember, there is a primary scar. This scar was an attack before, so you might be the one seeing the first attack. So how to manage them? Well, literature would tell you when to treat or when to suggest treatment for the patients. We would say that we would only like to treat the sight-threatening lesions involving the macula, papillomacular bundle, optic disc head, or major blood vessels, the ones with severe vitritis, and the ones that come in immunocompromised patients. So how do we treat? We use two things: antimicrobials and steroids to create the inflammation. The antimicrobials has many lines. So the first line described in literature is pyrimethamine, which is a folic acid antagonist. And the second line is trimethoprim, sulfamethoxazole, and others would include azithromycin, atovaquone, which are also effective against the cysts, and spiromycin as well, that is safe in pregnancy. So we give the patient the two choices: either conservative management, as literature would say, in 4 to 6 weeks, the lesion will resolve on its own, but the patient actually decided to go for treatment. So what did we give her? We give her prednisolone and azithromycin. So this is from the others, not the first line, not the second line. We depended on a prospective randomized trial done to compare the results of azithromycin versus trimethoprim, sulfamethoxazole. It's actually done on a small sample size, so it's only 14 patients who took for azithromycin and 13 who took trimethoprim, sulfamethoxazole. The end result of the study was the resolution of inflammatory activity, the decrease in the size of retinochoroidal lesions, and their visual acuity. And they found no difference between the two groups. So now we have a very safe antibiotic that can help us deal with these patients, because trimethoprim and sulfamethoxazole have lots of side effects and also the possibility of having Stevens-Johnson syndrome. So what was the outcome in our patients? After 4 weeks, her visual acuity became 6.6. There was a resolution of vitritis, sharpening of the lesion margin with scar formation and RPE pigmentation. So what I would like you to remember from this talk is that the early retinochoroiditis can occur in 20% of acquired toxoplasmosis. So you can see the patient of acquired toxoplasmosis. The anti-toxoplasma antibodies that you're ordering are not for you to confirm your diagnosis, but to exclude it. So if they were negative, that's when they are in use. Azithromycin needs more clinical trials with possibly larger sample size than the one we've used. And